das estruturas que precisam ser navegadas por artérias normalmente muito tortuosas. E eu queria saber se essa navegabilidade é adequada, é fácil navegar por uma artéria hepática muito tortuosa, ou no caso aquela subclávia também me parecia ser muito difícil, a navegabilidade pela aorta extremamente tortuosa. Existe uma facilidade maior nesse dispositivo? E gostaria de saber se há alguma experiência do grupo em relação aos stents com redirecionamento de fluxo para esses vasos viscerais.
In terms of tracking this device, traditionally we track it through a sheath. So the sheath is kind of the key. There's been some instances that the sheath may not reach. The catheters are actually quite long, so they can go sheathless, and they actually track quite nice. I think when you have a good stiff system, you actually track nice. They do have a significant flexibility, and they will adapt to arteries that have significant tortuosity very, very well as well. I don't really have experience in multi-layer stents, so I wouldn't be able to comment on that particular aspect.
Muito bem. Vamos dar sequência, então, convidando a doutora Jade Hiramoto para falar sobre diferenças de gênero nos biomarcadores inflamatórios e associação com a patência primária das endopróteses nas extremidades inferiores.
Thank you again for the opportunity to present here today. My talk is on gender differences and inflammation in the primary patency of lower extremity bypass grafts. I think that just in general practice, we acknowledge that women and men appear to be different in terms of prevalence and outcomes of vascular disease. Until about the seventh decade of life, women have lower overall rates of cardiovascular disease compared to men. But if you look at population studies, there's actually a higher burden of peripheral arterial disease in women compared to men. There have also been studies that suggest that women may have lower rates of bypass graft patency compared to men, and some of the reasons include smaller conduit in women, smaller target vessels. Women may present at an older age and with advanced disease, or perhaps there's a difference in the underlying biology of the disease in women versus men. We know that inflammation is a strong risk factor for future atherothrombotic events. Both C-reactive protein and fibrinogen are acute phase reactants. CRP is a marker for systemic inflammation, but fibrinogen also has important hemostatic properties. It affects platelet and red cell aggregation and is a strong determinant of plasma viscosity. And elevated markers of both CRP and fibrinogen have been associated with an increased risk of MI, stroke, and peripheral arterial disease. In addition, several population studies have demonstrated higher levels of CRP and fibrinogen in women compared to men, but this is really of unclear clinical significance. And many studies have looked at the role of inflammation and cardiovascular disease outcomes, but far fewer have evaluated the association between inflammation and graft patency after lower extremity bypass grafts. And it's really unknown whether these differences in the underlying inflammatory profiles of men and women actually are important in the outcome after lower extremity bypass grafts. So we asked the questions whether there are gender-based differences in the inflammatory phenotype of patients undergoing lower extremity bypass graft and whether or not this correlated with primary graft patency. Our cohort was a prospectively recruited cohort from 3 centers in Boston, and between 2004 and 2008, 225 patients were enrolled in this study. And this specifically was a study that wanted to examine the relationship between metabolic factors, inflammation, and outcomes after lower extremity bypass grafting with autogenous vein. So any patients who were treated with a prosthetic or non-autologous vein graft were excluded. And although patients with small areas of dry gangrene or small ulcers were allowed to be included in the study, any patients with a deep space infection, large ulcers, or any ulcer requiring debridement were not included. So blood was collected in these patients in a fasting state on the morning of the lower extremity bypass graft, and all samples were analyzed in batches at a core laboratory. All of these patients had a clinical examination as well as an ultrasound duplex study at 1, 3, 6, 9, and 12 months. And after the first year, the follow-up was spread out to every 6 months. Graft reintervention was left to the discretion of the operating surgeon, and we defined loss of primary patency by any graft revision or documentation of occlusion of the graft without revision. This is how we performed our statistical analysis. We then created cut points for both CRP and fibrinogen because we wanted something that was easy for a clinician to look at in terms of determining risk. So CRP was dichotomized at 5 milligrams per liter. This has previously been shown to be a high-risk subgroup, and it also represented the upper limit of our core laboratory reference range. And fibrinogen was dichotomized at 600 milligrams per liter because this represented the top quartile of values in our cohort. So these are the overall demographic characteristics of the cohort. In general, men were more likely to be current smokers, have a history of hyperlipidemia, and be on statin therapy. But women were more likely to present with critical limb ischemia and had significantly higher median CRP levels compared to the men. Although the women also had slightly higher fibrinogen levels, this did not reach statistical significance. In terms of the indications for treatment in the overall cohort, it was pretty evenly distributed between claudication, rest pain, and ulcer. 22 patients were undergoing a redo bypass. Most patients underwent a bypass with a signal segment of greater saphenous vein. And in about half the patients, the outflow vessel was the popliteal artery, and in the other half, the target vessel was a tibial or pedal target. And for these three characteristics, there are no significant differences between the men and women. We had 78 primary graft failures, or about a third in the entire cohort. Although this was, primary graft patency was slightly worse in women compared to men, this did not reach statistical significance. We then wanted to look at what the risk factors for primary patency was. We looked at the overall cohort, and then we stratified it based on gender. And we wanted to do this in order to predict variables for our multivariable model. And based on these associated, we included race, diabetes, critical ischemia, as well as CRP and fibrinogen in our model. We also used composite vein because this has been shown to be a high risk factor for graft failure. These are the results for the multivariable model for CRP greater than 5. When you looked at the overall cohort, a CRP level greater than 5 was not associated with primary graft patency. However, women with a CRP value greater than 5 were significantly more likely to have graft failure compared to women with a CRP less than 5, and this effect was not seen in the men. And this graphically demonstrates this in the overall cohort, although there was a trend for those with a higher CRP to have worse graft patency. You can see that these results were actually largely driven by the women in the cohort because no such effect was seen in the men. What about fibrinogen? This is the multivariable model for fibrinogen. Again, race was important in both men and women. But women with a fibrinogen level greater than 600 were significantly more likely to lose primary graft patency compared to women with a lower fibrinogen level. And again, this effect was not seen in the men. Overall cohort, again, this effect was largely driven by the women in the cohort. So in conclusion, women undergoing lower extremity bypass for advanced peripheral arterial disease appear to have a different underlying inflammatory phenotype compared to the men. We found that elevated baseline levels of CRP and fibrinogen were associated with lower graft patency in women, but not in men. And to us, this suggests that there's an important interaction between gender and inflammation in the healing response after lower extremity bypass grafting. Women with elevated preoperative CRP and fibrinogen levels may potentially benefit from more intensive postoperative graft surveillance, but we consider our results to be more hypothesis generating than conclusive. Thank you very much.
Muito obrigado, doutora Jade. Doutor Luiz Carlos, por favor, comentários.
Doutor Hiramoto, nós atribuímos durante um bom tempo o processo de menor sucesso nas cirurgias arteriais nas mulheres por causa do diâmetro dos vasos. E agora a gente pode chegar à conclusão que em algumas desses pacientes, mas não em todas, existe uma alteração que justifica essa desconfiança. Baseado nesses fatores, o PCR, fibrinogênio, existe alguma proposta terapêutica em que se refere à estatina, antiplaquetários, algumas coisas que possam diminuir, minimizar a possibilidade de complicar nesse grupo de mulheres potencialmente trombogênicas, vamos dizer assim?
Yeah, that's a great question. And, you know, I think that if you look at the women in the cohort, actually a significant number were not on statins, and it's very hard to know whether or not the anti-inflammatory properties of a statin would have made a difference in the outcome of these bypass grafts in women. It appears that, at least in this cohort of patients with advanced disease, that inflammation does play a significant role, that there may be something underlying the biology that's more important or as important as a small target or a small bypass graft, but it's really difficult to know. And again, we can do a better job with statins in this cohort, and especially in women. Whether or not it would make a difference is difficult to know.
Muito obrigado.